I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it.
Welcome to this episode of IDD Health Matters. Our guest today is Craig Sever, a registered pharmacist in this field.
Right.
Welcome, Craig.
Thank you.
Tell everybody what you do.
Well, I'm a consultant pharmacist. I spend the majority of my days consulting on the IDD population, chart reviews, lab reviews, those sorts of things, making recommendations wherever I see fit.
All right, chart reviews, lab reviews. What does that mean? That sounds like doctor work.
So
you look at...
I'm looking at their meds. I'm looking at changes in therapy, drug interactions, inappropriate doses, just anything that happens to jump out at me on a daily basis. And then I make a recommendation to the physician to kind of say, hey, is this really what you wanted to do? Is this okay with you? Are you aware of this? And let them decide if it's something they want to address.
You know, that's something we don't often think about, a pharmacist necessarily working in that capacity. So this is a little different than kind of standard pharmacy work, I guess. And it requires some special knowledge, I would think, related to this field and in the way medicines might affect people differently with disabilities sometimes, or things you need to be a little more aware of.
Certainly, yeah. I think, from a general pharmacy perspective, meds are meds, right? And we all know what their effects and side effects and things like that are. But sometimes in our population, it presents so much differently because sometimes in our population, they're nonverbal.
That's right. They might not use words to communicate, but they still communicate oftentimes, right?
So we have to learn that nonverbal. We have to be tuned into those little triggers that maybe are so subtle that you or I wouldn't notice them, but maybe the staff that works with them on a daily basis says to you, hey, so-and-so has been doing this, or so-and-so has been having this problem. What do you think about that? Will you look their meds over and see if you see anything? Right.
So is there an example of how, say, if a person's having a side effect from a medication, but they can't tell you what they're feeling? Do you have any examples of how that might look or how things might look differently in people with disabilities?
I wouldn't say my favorite example of that is actually one that could speak, but didn't actually speak in ways that maybe we understood. Okay. The gentleman lived in a small facility, a 4-bed facility, and was complaining that folks were touching his legs every night. And of course, the obvious question is someone
really touching their legs? Right.
Right. No, the staff's there. He goes to bed, but he complains that someone's touching his legs. And I was fairly new to the home, so I flipped open the chart and I went on through and I looked at what was going on and I said, how long has he been diabetic? And they said, well, his whole life. And I said, okay. And when does he notice this? When he goes to bed. I said, so he's got peripheral neuropathy of the legs. And the physician looked at it and said, well, he's in a DD facility and he's got some mental issues. He's hallucinating, and putting him on Seroquel.
That's one of the things we have to
and I said, I don't think the man's hallucinating. I think he's got peripheral neuropathy. Let's get him on a Neurontin and see if that person touching him goes to bed at night, goes away. And sure enough, it did. So I wouldn't say it was as much not communicating, but just communicating in a way that maybe we weren't hearing, that we weren't understanding, right?
Right.
And jumping to that conclusion of, well, he has a disability, he has a psych diagnosis, and now he's hallucinating.
That's one of the things we talk about a lot on this program is what we call diagnostic overshadowing, where we attribute a particular behavior or activity or symptom to the person's overall diagnosis, which is exactly what happened in that case. It said, well, he has a disability, he's psychotic or whatever it is, and let's put him on a medicine for that behavior or that psychosis, without ever really looking for another underlying cause. And that's where people like you can come in and really make a difference in a person's life, and get whoever's touching their legs all of a sudden disappear, right? By putting them on the right medication, or maybe sometimes removing a medication that shouldn't be there. That could be causing problems. That's different than regular pharmacy, I would think.
Yeah, it's much more hands-on. Back in
very
the days,
clinical.
Yeah, very clinical.
Yeah.
Back in the day when I graduated, you kind of had two options. Or three options. You either went to hospital, to retail, or to sales. That was sort of where you went. I wasn't really a retail kind of guy, and sales just isn't my thing. So I gravitated to hospital. Actually went back to work for the hospital that I'd been born in 20 years earlier. And we had a pharmacy director who was very progressive in his thoughts at the time. This was back in 87. Felt that we should have pharmacists on the floor. We should be reviewing med orders as they came in. Our system was set up that when the clerk would enter the order, we would get an entire profile along with the new order. And our job, we were assigned to certain floors, was to take those orders, look at that profile, look at that new med, basically do a consultation on, is this the correct dose? Is this actually what the doctor wrote, et cetera? And sort of do a mini consult right there on the spot. And then if there was a problem, go down the hall, grab the doctor and say, hey, this dose isn't right, or hey, did you see this? So that was sort of the early sort of foundation of my clinical consulting, right? From there, I went, I stayed there for about 13 years and had the opportunity to go to a true consulting role, which was what I'm doing now, back in 2000. And at that point in time, I worked for a company that was geriatric and DD population, which at that time was a very kind of two distinct populations, because our population wasn't living to be geriatric as much as they are now. Right. Some of the individuals that were there didn't find the DD population interesting, I guess. There wasn't enough wrong with them. And I was the new guy and I got them all. So I didn't know what I was doing. I was just going in.
I can relate to that.
Yeah, we didn't get this taught to us in school. No. We got meds taught to us. We didn't get this whole other segment of the population. So it was sort of trial by fire and going in with an open mind and looking at, for lack of better term, my own ignorance, looking at it as a whole without any preconceived notions. Sure. And then, of course, you do it long enough, and even a guy like me who's not the smartest can see patterns develop and I think there's something going on here, right?
I'm right there with you, man.
Yeah.
So you mentioned a couple of things that I want to touch on. One of them was that we don't get this training. Now I've talked about how physicians don't get this training, so pharmacists don't get this little aspect of training either. So what do you think are some of the key things that a pharmacy student should learn about this field?
That they're much more complex than sometimes they're led to believe. Because not only do we have all of the typical medical things that we have going on, sometimes they're camouflaged by the intellectual disability, the psych diagnoses, things like that. So they tend to be much more complex than what maybe they're first given credit for. I think that's one of the big things that I learned, obviously. And then I think the other thing is to give them a chance and listen to them and sort of peel away all those layers until you get to the real root cause.
Yeah.
I had a very good preceptor when I started, actually ran a retail pharmacy. And one of the things he always told me is, if you want the right answer, you got to ask the right question.
That is very true.
Right?
That's right.
And if you don't get an answer to a question that you're expecting, or you don't get an answer that makes sense, then maybe you asked the wrong question. So keep peeling away that layer until you get to the answer you want.
And I love that. But that's one of the things I talk about when we talk about teaching clinicians in general about this field is I don't need to teach them like the specifics of how to, say, take care of aspiration pneumonia or how to take care of a bowel obstruction. The clinicians are taught those things. Pharmacists are taught the side effects of medications and the interactions between medications. But what's a little bit different in this field is the different presentation of, say, medication side effects or the aspiration pneumonia in my case. And that's what I really think is, we need to focus on when we're teaching, up and coming clinicians and pharmacists and others in this field, is that it's just a different way of thinking about some of the same things that you already know, that you're already going to learn. and how much impact that can have on a person's life. Like that guy no longer has somebody, messing with his legs in bed anymore.
And was no longer on Seroquel, which we know is an atypical antipsychotic.
Not
It can make the
best.
diabetes worse. So
Yep.
it's like, so now we've sort of eliminated two problems simply because we looked at him as an individual and not just as a page of diagnoses.
Yep.
Right.
So the other thing you mentioned that I want to come back to is you mentioned that people with intellectual and developmental disabilities are getting a little bit older
Yes.
now because of many different reasons, which are good.
Right.
But they're also facing some of the things that we all get to face as we get older.
Right.
And so we have to orient ourselves a little bit differently to that. And we're actually coming to you from the Association on Aging with Developmental Disabilities Conference.
Yes.
We're in just outside of St. Louis at St. Charles, Missouri.
Yep.
And I've had the pleasure of being here probably 5 or 6 times now, which has been really great. You're on the board.
I'm on the board of directors. I've been
Tell
on
us a little bit about the organization.
Well, I let our wonderful director, Pam Merkel, run the organization. We just sort
does do a great job.
Yeah, we just sort of follow along and do what Pam tells us to do and nod and smile. I've actually, as far as the conference, I started on the conference committee back in 2016, 2017, and really didn't know much about it at that point in time other than, the little bit that I did know. The organization sets up this conference every year, 2 days in May. We try to bring together experts in a variety of fields, medical, pharmacy, therapy, whatever it happens to be. We have multiple tracks. We have a professional track, a social track, an administrative track, and we try to provide information to our folks that is usable to our people on the ground, that they can walk out of this conference and apply it to the folks that they're in charge of taking care of.
That's always my goal when I give a talk. It's like they need to have at least 1 or 2 things that you can take home and implement right away. That will make a difference.
Right.
A big difference.
And that's always my theory when I'm ever asked to present at these. I'm like, you know what? I'll come and my only request is take one thing home that you've learned. If you've learned one thing by listening to me babble for the hour, it's a success, and I'll consider it worth my time to do, But I try to keep it very, and I think a lot of our folks do, very hands-on. How does this apply to what you see every day? The organization is, this is one of our big things from an organizational standpoint, is this conference every year. It's growing thanks to folks like you and just coming out and supporting us it's fun to be around. It's fun to see people sharing ideas.
I agree, and I would encourage anyone out there who works in this field to consider coming to this conference, especially if you're working in the aging field,
right?
Or aging with disabilities field in particular,
right?
Which is what this conference is really all about. You're going to not only learn some things from people like Craig, but you're also going to get to meet other people who are facing some of the same challenges that you might be facing, and you can commiserate together. Actually, let me change that. You can find solutions together.
Well,
right?
Sometimes I've had people tell me, it's nice to just hear other folks are going through the same thing I'm going through.
Yeah.
Right? Just the fact to know that you're not out there on an island, that, this is the way other people have it too, and hopefully find a solution.
Yep.
Right?
So, Craig, one of the things that I like to challenge my guests with is something called 3 in 3.
Okay.
So it's 3 things in 3 minutes that you would like to tell anybody listening that you think could have a positive impact on the field of supports and services, maybe health and wellness for people with intellectual and developmental disabilities. 3 words of advice.
3 words of advice.
Can be as specific or as general as you like.
I would say, number 1, first and foremost, do not overlook the field because of preconceived notions or ideas. It's very rewarding and very challenging if you give it the time that it deserves and requires.
Like that.
Yeah.
And that's, like anything else. You put into it or you get out of it what you put into it, I guess.
Exactly.
The opportunity to do some really remarkable things in this field, I think is one of the benefits of working in this field, because you really can make a difference in other people's lives and help reduce people unnecessary suffering. You might prevent deaths. But you might do very small things like just help a person live a little bit little bit more integrated life that's less encumbered by health issues or medication problems or something like that, and that makes a big difference.
Yeah, and I think that our ability to impact and then not to be rude in any way, but to impact an 80-year-old individual who's had the wrong medications their entire life, you're kind of going in and picking up the pieces at that point. Yeah. I can step into one of our folks that is 30 or 40 years old, hopefully prevent all of those bad things that will happen by the time they're at 80 or minimize that effect. So there's actually more impact you can have sometimes on our folks now than when you see them at the age of 80.
You know, I'm really buying you time to think about two other things, and I'll tell a little story while you're trying to think of two other things. So, but this is a great story related to what you just said, where there was a gentleman that we had provided, services for many, many years.
Right.
But had been at the program where I was way before I ever got there. And it was actually a neurologist who came in and said, he's been on this medication for many, many, many years. It's not the best medication. It was an old, not to bash anything, it was an old seizure medication that we don't use very much anymore. Okay. And he says, we really should change him to something newer. And he got weaned off of that medication and put on something else. His seizures remained in control, but he started talking.
Yeah.
He had never talked before.
Right.
It was incredible.
Because he was so out of it.
He was so zonked out of it.
And what sort of quality of life had that individual had all those years? Because he could talk and never could. I mean, he physically could talk, but just didn't have the capacity to do it.
Yep.
Yeah. It's amazing.
It's very heartbreaking when you think about it sometimes.
Yeah, but it's also very rewarding when you can make those and see that immediate impact that you have on somebody's life and see them sort of just blossom and come out of what they've been.
Speaking of immediate impacts, you have two more.
Oh, wow. I'll tell you, one of the things, and I don't really know, this is such a huge, complex issue. I really don't know how you address this or how we address it. But I think funding for some of the medical care that our individuals don't receive like they should. Specifically, I'm in Illinois trying to find sedation dentistry for folks that are Medicaid because they don't accept the Medicaid, but I have an individual who, because of years of poor oral hygiene and bad meds and one thing and another, now has 6 rotten teeth and behaviors. So we're putting him on other meds that we don't need to, where if we would just pony up for the sedation dentistry, get the teeth fixed, pulled, repaired, whatever it happens to be, we could avoid a whole lot of other meds and a whole lot of other problems down the road.
So advocate for funding.
Especially in those. I mean, we have a lot of people advocating for a lot of different funding in a lot of areas, but I think, at least from what I see on a routine basis, dental is really overlooked.
I couldn't agree with you more. That's even more challenging to access for adults in particular with intellectual and developmental disabilities and healthcare.
Right.
Dental is the biggest unmet need, and that's a perfect example of how. I mean, could you imagine living all of your life with terrible dental abscesses and how you might have adverse behaviors and all of that kind of stuff, and then to get put on some behavior medication for your tooth, that would be malpractice in the regular world, wouldn't it? If you went to the dentist and the dentist said, you keep on hitting your mouth and you have this big abscess, but we're just going to put you on a medicine to keep you from hitting your mouth and zonk you out, that wouldn't be the right thing to do. Yet that's what happens a lot of times.
Absolutely.
And you mentioned the funding aspect. He needed to go, that particular person, sounds like he needed to be sedated to have extensive dental work done. That could fix all of that.
Right. Yeah. And we've solved the behavioral issue, we've solved the unnecessary med issue, we've solved his quality of life, most importantly, with one thing, and that is find somebody to pay for sedation dentistry.
And those things can reduce healthcare costs down the road when we take care of them earlier.
Right. Yeah. We're looking at the immediate gratification versus not transferring that out 5, 10, 20 years on what that'll do.
We've gone over your 3 minutes, but I'm not letting you off the hook. So
I can come up with another one.
You got one more thing?
I can't. Yes, I do. I think it's important to continue what we as an industry are doing, and that is to continue to sort of interact, to exchange ideas, to be more open to each other or available to each other. this conference helps that because we bring people from California and Oregon and all over, different sets of problems, but still the same individuals and maybe the solution. So I think that networking needs to improve. We have a lot of conferences and a lot of information out there for the geriatric population, for the pediatric population. Pick one. How many conferences are out there for the DD population? How many studies are truly things that really look at effectiveness are out there for the DD population? So a lot of times we're flying blind on this, and then we don't understand why we can't figure these things out.
And that networking and getting that messaging out is part of what we're doing here on this podcast. Craig, thank you so much for being a guest. I really appreciate your insight and all the things that you've offered, but more so what you do in this field.
Thank you very much. Same to you, sir.